Good evening, chairpersons and dear friends. Warm wishes from a place called Tirunelveli, closer to Kanyakumari, all the way from there. So I do not have any financial interest or relationship in the following topic, which relates to drug depository contact lens, a novel one that prolong antibiotic corneal contact time in bacterial keratitis, results of a randomized control trial. Up to 5% of all blindness are due to infections of the cornea, and microbial keratitis accounts to nearly 1.5 to 2 million cases per year. Prevalence is as high as 11.3 per 10,000 population in South India. And presently, loading dose concept of antimicrobial agents in the form of ocular topicals are the preferred treatment options. However, precorneal factors and anatomical barriers negatively affect the bioavailability of the drug in the lesion. So with this background, we propose to study the efficacy of novel therapeutic contact lens that can increase the overall contact time of antimicrobial agent, serving as a drug reservoir in subjects with bacterial keratitis. It's a randomized open label clinical trial, 40 eyes, conventional sample. They were grouped in 1:1 ratio. Group 1 received only topical antimicrobials. However, Group 2 had a drug depository contact lens with a central reservoir along with fenestrations to enable capture of every time applied antimicrobials. So we followed up on 12th hour, days 1, 3, 5 and 14. Pain was also evaluated in a 10-point scale. And a separate study on availability of the drug in the central reservoir was also analyzed over time curve. This is the proprietary design. You can see dual base curve design, which forms a central reservoir for drug and fenestrations which enable capture of every time applied antimicrobials. The results, corneal infiltration or the bacterial keratitis severity scores on presentation in Group 1 and Group 2 were comparable. However, resolution by 12 hours by day 1, day 3 and day 5 was comparably better in the contact lens group than with drug alone group. This is a representative case of bacterial keratitis, a central lesion keratitis with an abscess. You can see the drug depository contact lens with fenestrations, and this is by 12th hour, by day 1, day 3 completely resolved, and day 5 and day 14. Another case example wherein a paracentral lesion, staphylococcus, which healed before day 3. You can see effective healing by 12th hour and good healing by day 1. The visual acuity also, there was a mean of 1.5 line improvement in vision noticed in day 1, which improved by another line in day 3 in the contact lens group. Significant visual acuity gains were observed in drug depository contact lens group in days 1 and 3 respectively. Pain was also comparable at presentation between either groups. However, there was a gross reduction in pain in the first 3 days in contact lens group when compared to drug alone group. Similarly, reduction in haze and AC reaction was also more pronounced in the first 3 days in the contact lens group. Larger sized ulcer, this is a gram-negative ulcer which healed within 14 days effectively within the first 5 days in contact lens group. As I said, the drug retention in the central reservoir was studied separately, and the drug was found in the precorneal space up to a period of 4 hours. So poor drug availability is a major concern associated with the ocular dosage forms. So in this study, we aim towards retaining the drug in the precorneal space by using a very highly specified depot contact lens. The fenestration in the lens enabled capture of every time applied antimicrobials. As we clinically documented resolution of infiltration, improvement in the bacterial keratitis severity score, the pain resolution in the first 3 days We recommend that the treating physician may remove the lens after 3 days, but the first 3 days are crucial and the lens need to be there in place. Further studies we have taken up, and we are also working on extension studies to evaluate reduced topical loading dose burden also for additional safety and efficacy data. To conclude, the drug depository contact lenses may be indicated for therapeutic use to promote effective healing and pain relief in cases with bacterial keratitis. The concept of using novel drug repository contact lens over the lesion is effective in prolonging corneal antimicrobial availability, which can affect the overall outcomes in management of bacterial keratitis. This can reduce the treatment burden of antibiotics, burden on the medical staff, improve patient tolerance, and also reduce drug toxicities, and may change the present practice pattern of loading dose concepts. What is known? BK causes unilateral blindness in developing countries. There is an unmet need for effective treatment option as to drug delivery. An intense loading dose is required. What the study adds? Drug depository contact lens extends corneal drug lesion time and healing in bacterial keratitis. I thank you for your attention, and you can find this published article in British Medical Journal. Thank you one and all.
Sir, where do we get this contact lens?
Yes, it's a proprietary thing, and we are working for marketing license. Maybe in a month it will be available in the market.
And it's like a rigid lens?
It's made of aquafilcon A material, and it is not a rigid lens. It's a kind of soft lens, almost similar to that of Rayner foldable IOLs.
And the frequency of the drops is reduced in such cases,
it's
or
reduced.
you have to
It's
dip
reduced.
it in the drug?
That's what the methodology is not been extensively described in the presentation, but we had it every 2 hours in the first 2 days, followed by 6 hourly, that's 4 times a day in the next 12 days. But now we are working on even further reduced burden concept, where there are 3 arms, the third arm getting only 4th hourly antibiotics right from the beginning.
So is this the empirical treatment that we are giving here in all the cases?
Is it?
Is the empirical treatment we are giving here a broad spectrum antibiotic we are talking about?
Well, what we do, we have microbiology unit associated within the hospital. So first what we do is, when we see a suspected cases of bacterial keratitis, we do a scraping. We don't start with any antimicrobials. Then based on the gram staining properties, in this particular randomized control study, we used only a 4th generation fluoroquinolone as a standard agent. However, presently we are also working on amikacin in gram negatives.
Question, sir, regarding this. Although this is a randomized control trial, sir, but those 2 study groups, were they comparable in terms of grading of ulcer?
Yes, that's what I said. At the baseline, they were comparable.
And if we have to continue this contact lens for a longer period of time, then do we need to change it?
I said in this particular study, we continued for 14 days without any toxicities of the lens. But then, since we find good response within the first 3 days, we recommend the physician to use it for the first 3 days, and after 3 days, whether to continue or to discontinue based on the clinical evidence of healing, it's up to the treating physician.
And just like if we have the contact lens over the surface, then staining of ulcer and all this, does it get difficult a little?
You can remove stain and reapply also.
Reapply, and then when we have removed it, we have to keep it in like antibiotic solution or something?
But no. The contact lens cassette solution is available.
Yeah, right, and that will be having the typical soft contact lens washing solution?
No.
That's different for this?
Yeah.
Any experience about in fungal ulcer?
Yes, we are also trying on some of the fungal keratitis, but then we are making a slightly larger fenestration size. So that is now I would say generation 2 lenses what we are working, because most often fungus what we see in our area are dermatitis fungus, and natamycin is the drug of choice, which are polyenes. They are large chains, they are suspensions, not clear solutions. So retaining a polyene on the surface through the fenestration may be a challenge. So we are trying to make a larger fenestrations for fungus.
If it is getting retained there, then probably over the surface, if natamycin is staying for a longer period of time, will it cause any ocular surface?
No, we don't know. We just have some case reports on fungus. We are not an authority to right now talk on fungus.
Can
Maybe
we
are-
immerse the lens in the antibiotic and then place it? So we
No,
don't even
no,
have
no,
to-
no, no, no.
Pre-soak
That
it
is
as
for a sustained release property. Here we want to have a potential precorneal space, like an antimicrobial lake, to retain the drug in the space.
Can we use any semiscleral contact lens for this, sir?
Can we use?
Semiscleral contact lenses that we use in cases of dry or
But
something?
we don't retain drug
Yeah.
for a longer time.
They do not have that fenestration that you.
Not alone that, they just on the top of the surface, the epithelial surface, we don't have a potential space, a lake. So this is a dual base curve designed to make a lake.
So usually in an infection, we try to avoid any contact lens on the eyes. We want to remove it. So how does this work against that principle? Like,
Well, let's take an example. We have a burn. It's better not to have something on a burn, dermal burn. But if you can retain some moisturizing thing, or if you can retain some active ingredient over the burn, then yes, we also use some wet gauze or something. It's something similar. Why do we not want a foreign body? It's a foreign body. But at the same time, this foreign body is meant to retain drug. It's like applying a bandage. You want to have medicine, you want to have the medicine stay there for a longer period of time.
I think also depends on the material, I think, which prevents
I wouldn't
infection.
tell the material property outweighs here. It is just the drug which is needed stays there for a longer time.
So ask a question.
Excuse me, sir.
Mm.
Recently, I have come in a contact of a product that
Contact
I
of?
asked you that umbilical cord I am working
yeah,
on.
yeah.
So what they are doing on amniotic membrane, they are coating with PHMB.
Mhm.
So have you think of or plan of make it like coating of PHMB that whether we can use it for acanthamoeba in
Yes, PHMB is a known agent that can be that acts against the trophocytes of acanthamoeba.
yes.
That's for sure. But can you retain PHMB on umbilical cord material or on the amniotic membrane surface for a longer time? That becomes a challenge.
That's what I'm asking. Like, can you use it in contact lens that may help for acanthamoeba cases? Because we don't have any definitive
No,
treatment.
we can
for
directly use PHMB over this lens.
Pardon?
We can directly use PHMB
Over the lens.
over the lens. Yeah. Why do we need any dispensing agent like amniotic membrane here?
So suppose I have one acanthamoeba case.
Mhm.
So I can put one drop of PHMB in
Yeah.
BCL and
Yeah.
I put it over there.
Not BCL. This is a highly specified lens. So you can use this lens.
So
and
what
you can
kind
use
of lens should I use in this cases?
Yeah, that will be available in market very soon, within a month.
Okay.
Yeah.
So that will be for the first time I have to put one drop of PHMB and then like that, or like I have to put it.
Either way, it has fenestrations. They
Right.
observe.
Okay. Thank you.
Any criteria for ulcer size in which these lenses can be used?
Sorry?
Any criteria for ulcer size?
Ulcer
grade of
size,
the
yes.
ulcer.
We had ulcers of different sizes, but this series it is 2.78 was the average ulcer size, but we also had over 4.
Okay, sir, very excellent
you.
presentation and very informative.